We'll be talking about the cervical scan, and my name is Kent Kaiser, and I'm a faculty with the North American Institute of Manual Therapy. First thing that we're always interested in is to make sure that we've asked all the mandatory questions for this area that'll give us an understanding of whether we have any kind of cardinal signs and or non-cardinal signs that would create any problems in our having that patient there for that session of physical therapy. Within this, questions that we want to ask is to understand a more clear understanding of the history of trauma related to this person visiting us today. We want to make sure that we understand clearly whether they have any history of rheumatoid arthritis or upper respiratory tract infection that might give us an understanding of some ligamentous issues. An example of that would be Gristle syndrome, which is a respiratory problem that affects the pharynx and therefore might provide laxity of ligaments, and so this would give us a clear understanding. Other questions that we want to know generally that day: are they going through any problems with dizziness, nauseousness, any kind of vomiting that's occurred with neck motion or any of the with pain that involved with that. We're going to also want to know if they have any severe ongoing headaches that might give us some clues to the problem. We're going to be wanting to understand things about any kind of unexplained weight loss related since the problem has occurred. Also, whether a sneeze or a cough produces any severe pain in their neck, other places. And we're going to want to know about their history of medication recently, whether they've been on steroids. Some people will come in and they may have a history of getting some kind of a joint block done in the cervical region, and so multiple injections are going to be something that we want to know about. We want to know about whether they have a history in the medication of anticoagulants. We also want to make sure that there's no particular signs or symptoms that they report to us that might be of interest to that day, particularly to the movements we do. Examples would be any quadrilateral paresthesias, any kind of odd paresthesias of the lip area, any kind of hemifacial types of problems. Again, anything that's going on that might lead us back to think of all the cardinal signs, and those are in particular important to us. Those are going to be a history of drop attack. A lot of times you can see that occurring when a person walking unsteady into the clinic that first day. So it's always good to observe your new patient when you can. During observation, as talked about in the overview earlier, we're going to be looking for things in this area in particular that we're going to want to ask the patient about that may be something to give us information about the problem. In the neck and cervical area, of course, any kind of surgery that might have been done in that area, observation of fullness in the throat that might give us a sign of goiter, some kind of lymphatic type of situation going on we want to know about. As we look at the person from different angles standing, of course, we want to see the relationships to the neck that will be coming from below, and of course that will be talked on in individual section. Particularly to the neck, any kind of scoliosis, I think, is of a particular interest that can help us understand mechanics that are going to go on later. We're going to be able to look at hairline. We're going to be able to see if there's any kind of congenital possible problem. Some of those things we talked about in the overview would be some kind of a skin somite type of problem like a cafe au lait or a port wine stain that might tell us about some congenital issues for anomalies in that region. Again, we're going to be wanting to see if there's an unusual positioning of any of the body parts in relationship to the neck, and in particular whether they have some kind of deformity that might be coming from some a congenital problem like Sprengel's, where they might be having some problems with having a difference between clavicles, etc. So we're going to be looking at that standing, any kind of 3 views. Next, I'm going to have the patient sitting here so that we can see when we sit down if anything changes within that visual area for us through the neck and spine as we observe. So we can have 2 views to help us and move us into the next section. On the articular part of the exam, we're going to be trying to have the patient established in a position we're comfortable that they're solid on the table, that they can be as upright as possible. They may be biased because of their pain into a less than optimal position. We're going to have them go through planar range of motion, with the head going to be in long neck flexion first, seeing again their willingness to move actively on command. Then we're going to give them an overpressure. They overpressure at end range if, again, they have full range and no problem. We'll look at the inert ligamentous and other structures in that region. Is there any pain? Is asked of the patient. We'll bring them back up and out of that position, less than that full overpressure, and then provide resistance at this point to see again, does the contractile elements have any strain with that? If the patient is more in a subacute situation, we may, through the full range actively to see willingness, may have to move them out of the position a little bit to do overpressure if they're uncomfortable, and even more out of the position if they need resistance at a more comfortable level, just depending on the level of strain that's occurring. So that's long flexion. With long flexion, we can also do short neck flexion. So I'm going to have him think about pivoting through the axis of his ear or about nose level. So he's doing a nod like yes. And he goes down full range to show that. Again, that's bringing in the upper cervical region into that short neck flexion. We again do a bit of overpressure. Again, I'm giving him support in the lower neck, hand pressure a little bit to give overpressure. And again, at that point, bring him slightly out so that you can bring in some resistance to that. A third motion that we can do is also have them do an axial position where they do a more protrusive position. Again, putting the lower neck into flexion and the upper neck into axial, more of an axially extended position. And we're, again, probably not going to be doing too much overpressure or resistance in this extreme position, but it gives us a sense at full range what they can do. Then we'll go to long neck extension, where again I place my hand in the CT junction to give them some support. Again, some people will pivot through the forehead. If you think that you need to give them a shorter lever, you can bring it through the maxilla, having them look up to the ceiling. Now this is full range. Overpressure very delicately here, and probably going to bring them out of this position a little bit to do any kind of contractile resistance. Then you're going to bring them into a axial extension, okay, which is going to be long neck position for the short, which is basically up tall, and from that I'm going to bring him into a little bit of just cranial extension. Again, it's going to be a shorter range here. Again, overpressure. Again, if you do resistance here, very carefully. And then lastly, back into that axial position, long, so now he's in lower neck extension, upper cervical flexion. It's more of a chin tuck position, but not trying to shear too much. And then again, we may be very careful if we do any kind of resistance or overpressure there. I'm going to have him pivot here so that you can get a better view. From here, we'd want to have the person, I like to go to rotation. Again, palpating with my back, my hand on his back CT junction so I can see and feel the rotation coming down through into the thorax. Some kind of, again, visual or hand position to estimate about the range of motion he's doing. From here, I'll have him rotate to the right. Okay. Again, I'd like to see that the person could be able to come toward touching fingertips at least, and that gives you an indicator of whether they're willing to turn all the way. From here, I can do overpressure and let it come off a little bit, and then again, the resistance to look at the contractile elements. Of course, doing this to both sides. Willingness to move, overpressure for inert tissue, off a little bit, back to some resistance, back to the middle carefully. Side bending or lateral flexion, so he's going to be coming from the lower part of the neck through the full range. Again, careful to keep them in a straight position, not letting them go into too much flexion or extension in that position. Willingness to move through active range of motion, once again, overpressure, lightly reduce the position, and resistance. Again, in this case, the person would be fairly lengthened, so we'd be looking only at minor strains if there was anything here. Of course, any of these times you can reposition to a less aggressive position if you feel the strain is at a grade 2 or higher. We do that again to the other side. Willingness to move through active range of motion. We have overpressure, slight release, or appropriate release to resistance. Again, stabilizing on the shoulder and back to neutral. Okay? Some people would like to do a little short flexion that's sometimes a little more awkward to the patient, probably best looked at in a more specific biomechanical exam. This has been the more planar movements. If successfully moving through this or needing to find out a little bit more information in your scan, we start going through the quadrant positions. The quadrant positions are going to give us a combination of movement. The ones that we'll look at here, flexion toward the axilla. We're going to see if they can combine into flexion, rotation, and side bending. Again, actively moving to give us willingness. Overpressure. And we can do resistance in this position as well. We can come back up, again, do the same thing the other side, and then the opposite of that would be a combined motion of extension, rotation, and side bending, which would be Sperling's position for testing. From here we can do gentle compression. This is a position that you can sometimes bring out stenosis and or potential compression on nerves. So you want to be very careful with any kind of compression here. Resistance, if necessary, is going to be very, very careful in this area. We're also, in our articular scan, going to consider the scapula and the shoulder girdle as it works in this region. For this, we'll have him go ahead and do elevation of the shoulders. Again, see his willingness to move through full range. Overpressure is going to be in a superior position with elevation. And then resistance is going to be with the muscles lengthened in the scapular region. So I'll ask him to hold against me, pulling you up. And he's pulling in a caudal direction against me. Full depression of the shoulders. Then we're going to have overpressure again at the end. Let go, and then resistance is going to be, don't let me push you down. Meet my resistance. Again, seeing if he can resist you in that position. Two other planes of motion for the scapula are going to be, of course, protraction. And in that position, we're going to hold forward full range, overpressure forward, let go again, come back with resistance. Don't let me move you, or meet my resistance, seeing if he can build tension against you without any kind of strain or pain. Lastly, in this position, we'll look at retraction with, again, overpressure and holding that position against resistance. Don't let me move you backwards. It's doing a good job, and back to straight. Of the articular position, one of the last things we can do is just do a quick screen of the upper extremity at this point to see if articularly, one, they can go through general range of motion over their head. So I'm going to see active motion of the arm overhead. That time we can also see if we have concomitant movement through the CT junction related to the neck. This arm lift overhead. And articularly look at just general movement of this also by doing a reverse position of one arm versus the other, this arm behind, to see what general range of motion is. Looking at wing in the scapula, other kinds of relationship with the scapula. So we can then go to the other side and compare. We know that there's going to be tendency for a person's dominant side not to always have as much range of motion, but symmetry could be an ideal. And relax. The final component of the articular section is we're going to talk about traction and compression. Once we've screened the range of motion issues with also the selective tissue components of overpressure and resistance, we can put the person in a neutral position, see how they fare with just gentle compression, see if that brings on any significant symptoms or signs. If that's okay, we can also do a gentle traction. Again, in traction, try not to cover over the ears. If they have any vestibular issues, that might set them off. So if you can come up around and away from the ears and bring traction up gently. Initially, the compression is going to be looking at putting pressure on the different articular structures and, of course, onto the disc. In traction, we're going to be looking at ligamentous and any myofascial elements that might be irritated. If that is good in the scan, then of course we can be a little bit more assertive and we can put them into those various positions that we looked at in range of motion with compression and traction occurring at any one of those places to elicit more information. And we talked about one of the positions being quadrant position, the Sperling's position, again, a specific compression in that position to look at any kind of neural compromise or stenosis in the joint. So quadrant positions can be done as well. In the next section, we're talking about neural conduction. First thing we're going to look at is dermatomes. When we come into the area, we'll use Kleenex in this for light touch and we'll use a paperclip for this demonstration for sharp, dull discrimination. We're going to come in and remember what was said. We want to look at an area that's going to encompass the whole dermatome here at C2 in that suboccipital region. We're going to come into 3 into the mandibular region for light touch. Remember the hair issues that were talked about in the overview. Here we're going to be looking at the yolk here for C4 as we bring him around into the deltoid region. And again, you may have a particular area you're looking at, but remember that dermatomes can change in where they express some lack of feeling over time, so you need to look at the whole area. For 6, we can come in through the outside arm. The hair gets in the way, so we're going to come into this region where we look at the tip of the finger for 6. Bring it up to the thumb. 7, we're going to be looking at the tip of the middle finger and index finger. 8, we're going to be looking at the pinky. And then T1 up the ulnar side of the hand and arm. And T2 is that inverted Y position that we look at through here in the axilla and chest region. For the sharp dull, typically you're going to actually use something more sharp if you have it. If you're concerned about that, you can use the paper clip. You're going to be looking at those same areas for suboccipital for C2. You're going to be looking at the submandibular for 3, the yoke for 4, deltoid 5, again down the arm, the back side, coming over here toward the thumb, depending on whether you're worried about hair for 6 or thumb for 6. 7, T1, or 8, excuse me, and then T1 along this region and into the axilla. The basic procedure will be as typical. You're going to be asking one consistent way for yourself that you're going to identify what it feels like to the patient. My preference is to ask the person to close their eyes and then just say yes when they feel that light touch at any of those given points in the dermatome. Same will be true with that. As you follow, you let the person see what you're actually touching them with. Again, trying to be consistent with your touch. Close your eyes, say yes when you feel that, and going through those different areas. You may want to vary where you do the touch so that you're not giving them an indicator at any time that you're going through a sequence, if you're uncertain whether they're really giving you a full or accurate answer. Continuing the neuroconduction, we're looking at DTRs, deep tendon reflexes, and then we're again trying to correlate whether we're having any kind of nerve root palsies by seeing a correlation between the different parts of the neuroconduction. With DTRs, we're again going to come in with the patient and we'll go through a sequence here and showing that we're thinking about technique with this because we want to elicit the most specific reflex that we can at the place we're looking. For the upper area here, we're going to come to the scapula at the border of the superior border. We're going to come, and I'm going to use my left hand for this. We should be ambidextrous as possible, coming in a glancing blow so we can come right onto that point. And usually what the reflex is going to look like is a muscle twitch or a kind of a compression in that. We don't always see a lot of activity at the reflexes. Then from here, we'll come and change him over. That was C4 at the levator scapular region. Deltoid, any area, I like to come into the anterior side. Again, looking for the muscle twitch for C5. We come to C6, we can come into the brachioradialis. We can either come in for a glancing blow that should elicit a shunt reaction, not overlap into the biceps, or the traditional at the point of attachment, sometimes difficult to get right on the tendon to get a wrist kind of flicking action. You can also go into anywhere in the wrist extensors to look at that particular level. C7 is, of course, the traditional triceps. I like to get the muscle on a little bit of tension because that elicits a little bit stronger look at the reflex. We're going to come in and there's a nice twitch. We look at the triceps for C7. And C8 is going to be typically difficult to see. It can be either a look at a reflex into the hypothenar region by trying to elicit a stretch on the pisiform and through that area looking for some kind of indentation. Not always something that's real clear, so probably not an orally valuable test to do. Myotomes are another part of the neuroconduction system we want to look at in line with all the other things we've just recently looked at. If we start back into from the different nerve roots. We're going to be looking at C4. C4 is going to either be tested by looking at the diaphragm with full excursion, take a deep breath, and out, and or it can give a quick stretch to see if they can go through a nice full deep inspiration. And of course, inspiration we can be looking at if there's any kind of dural irritation. With this, we can determine whether they have the ability to contract both sides of the diaphragm. The levator scapula is certainly a great C4 muscle. We can either do that simply with shoulder shrugging, but of course the traps are going to be very much into that, so we can bring the arm above the head, stabilize, and do some downward rotation to see if, again, they can stabilize through the levator scapula. Bring your arms down. Thank you. We can turn him to take a look at C5. Again, deltoid, which could be abduction motion, is going to give us a good idea. You notice that I'm usually stabilizing slightly just to make sure there's not doing any substitution patterns through the deltoid. Another C5 muscle that we can use is infraspinatus as an alternative if for some reason we can't use our primary muscle. When we come down to the biceps for C5-6, we can get a good contraction through that. As we said earlier, that is a spurt muscle, and we can take a look through that. We can look at an alternative C5 as being the subscapularis with either a internal rotation, isometric resistance, as well as an alternative muscle that we can look at. When we come down from there, then we're going to be looking at C7. C7 primary muscle we can look at is triceps, and we can certainly put it in a shortened position on somebody we don't think is very strong, or if we need to look closely, we can put them at a more disadvantage above if that's not a problem for the shoulder. Alternative C7 is going to be our wrist flexion, and we can pull up on that. Good. And we move down to C8. We're going to be looking at the thumb. Thumb's going to be supported so that we're not having overwhelm of the joint that might be arthrotic on anybody, so holding into extension of your thumb, a hitchhike position, and then we're going to be pressing down to see if they can support against that. Alternative for that is going to be the deviation from the ulnar side, so we can ulnar deviate and take a look at that. And then we go to T1 where we're looking at abduction, adduction, the interosseous, whether they can keep a grip on our fingers, or if you like, some light paper, and see if they can hold without that slipping out. On all of these tests that I did, our key component that we're looking at is whether this is an issue of muscle weakness or we can see that there's a fatigable weakness. The fatigable weakness is going to show by if we feel the muscle starting to break on our test. We're going to repeat the test and hold it for a sustained amount of time, 3 seconds or longer, to see if we start having a falling off of the contraction. And this neural conduction issue is going to be because the motor units aren't able to sustain the information versus just the muscles in themselves not having the strength to hold against your pressure. This is going to be true on any of these things that we looked at. Related to the neural conduction, we've just looked at lower motor neurons. Of course, there's upper motor neuron that we want to consider. And in the cervical upper quadrant area, we're interested in a couple of different ones. One of the ones that we'll look at is the Hoffman's test, which is going to take the middle finger in a relaxed position and some noxious stimuli applied to the tip of the finger, which you're going to watch what happens with finger. Of course, it moves a little bit, but if there is a pathological reflex, what we're going to see is we're going to see a drifting of that finger toward the thumb, or the thumb moving toward that. If we're uncertain whether that was just response to our noxious stimuli that's pathological or not, we can increase the information that's coming in there or to us by creating what's called a dynamic Hoffman test, and that's going to be asking the patient to move their head in an easy, gentle flexion forward, which we've already screened earlier. We know they can do this, come up and down a few times. This is going to stimulate different components of the neural system. Then we come back and redo that noxious stimuli again and seeing if there's a stronger response to that reflex. The other thing we can look at through here is clonus, and clonus we can achieve by taking the wrist and the hand and going through a quick supinatory motion to elicit a beats of motion or tremoring that occur. And again, remember that greater than 3, more like 4 or more beats that occur from that is going to be a concern for us when it is in line with other problems that are occurring. Of course, in the next sections, we'll be talking about those pathological reflexes that we can correlate to that, being the Babinski test that we'll see in the next sections, as well as looking at the slump test both for the thoracic and lumbar region. As we come toward the conclusion of our scan, we're going to want to look at some special areas, one of them being different vascular potential compromises. In this region, we're going to want to look at the pulse coming through the brachial artery. We may want to come up and check the carotid artery. And then we can look at the radial artery and, again, ulnar if we wish through this region. This leads us into potentially screening especially the thoracic inlet area here, or what is traditionally called thoracic outlet syndrome potential. We'll do that because we've already identified pulse. We can use any of the tests that are described in various places in text, such as Addison's, where you're going to take the arm in the low position back, feeling the pulse at the radial area. You're going to have the patient turn his head, bring your chin back into a position like somebody's blowing in your face. Good. And then you're going to take a deep breath. And as he breathes in, deeply inspiring, you're going to feel for any diminishing of the pulse at, in this case, the radial area. Other tests that are like that, of course, are Allen's test, which looks similar, except turning away and the arms up high. This also looks at some potential for neural mobility, where we're going to simply do some very easy traction through this area to look at T1 type of region here or median type of stretch potentially through this region. Another test that we can do here also is Halsted, which again is going to be somewhat of a down here in the low position, but instead of head forward, turning away. Any of these tests are going to give us a general scan for potential problems in the thoracic outlet area. We're going to look at the scan for the cervical region in a clinical kind of a scenario. At the end of that, we will then have a section that breaks down into individual components for more detail that you can look at on your CD. I'm going to look at you standing, please. So if you're standing tall, let me just have you be comfortable there. Good. Turn facing away from me. Okay. Again, turn back this way. Could you sit down, please, for me? Great. I'm going to have you go ahead and bring your chin to your chest. Is that comfortable for you?
Yes.
Good. I'm going to give a little overpressure just to kind of see if that creates any problem. Any problem?
Nope.
Good. Back off just slightly, and each time I'll have you back off from that motion, and just see if you can hold against my resistance. Any problem there?
No.
Good. Could you gently bring your head back up and look up to the ceiling, full range that you feel comfortable? Great. I'm just going to take a look at a little bit of overpressure. Good. And back off a little bit and a little resistance. Super. Can you bring your head straight here for me? Could you bring your head and rotate to one side or the other? Full range. Good. I'm going to give you a little bit of that overpressure. Any problems?
No.
Back off just slightly. Good. And resist me as I try to turn you. Good. Can we do the same thing the other side? I'm going to have you back off slightly and resist me. Super. Okay. Come back to the middle. Could you bring your ear toward your shoulder? Again, overpressure. Back off a little bit. Hold against me. Good. The other side. A little overpressure. Good. Back off and resist against me. Good. Now looked at the lower part of the neck. I'd like to do is have you just tuck your chin in for me, tight, nice and tall. Good. It's like somebody's blowing onions in your face. Super. Had that done before. Hold right there again. Don't let me move you through this range here. Good. Okay, I'm going to have you protrude your chin forward a little bit. Again, nothing that's going to hurt you. Super. Hold a little pressure there. Good. Bring your head back to straight. Now, what I want you to do is just take your shoulder blades, and I want you to bring them, the scapulas here up, elevate them. You're going to hold them there. I'm going to give you a little overpressure. Good. And I'm going to have you resist while I lift you up. Good. Push down straight, overpressure, and hold against my resistance. Good. Forward, if you will. Don't let me, again, press you through and resist. Go ahead back. Hold. Don't let me pull you through. Good. Could you just bring your range of motion with your arm over your head? Good. And it moves all the way through your CT junction, which is great. And we're going to bring the arm over here. Good. And then I'm going to have you just go ahead and bring your arm behind your head on this side, this one behind your back, just to see if you can touch each other up there. Good. Can you do the other side? Good. Relax here. I'm going to just put my hands on top of your head in this nice sitting position and compress. Is that okay? Mm-hmm. Good. We're going to just pull through there, do a little compression. Any problems?
No.
I'm going to give you a little traction. Any problems?
No.
Good. Range of motion-wise, could you just look down to your armpit for me? Any problems?
No.
I'm going to give you a little overpressure. Any problems?
No.
And I'm going to compress through there. Could you look to the other side? A little overpressure. Any problems?
No.
And I'm going to give you a little compression. Any problem?
No.
Good. Come on back for me and look up and away. Is that okay to go that far back?
Yes.
I'm going to give you a little bit of overpressure. Good. And then just a little compression. Good. I'll give you a little traction. Any problems with either one of those?
No.
Good. The other side. I'm going to give you a little compression and a little bit of traction. Good. Next, we're going to be looking at just how you do with your nerves, okay? So I'm going to take this little light Kleenex, and I'm going to touch different parts of your upper extremity. And you're going to have your eyes closed, and you're going to tell me when you feel it by saying yes. And you see how that feels right there, okay?
Okay. Yes. 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 Yes.
Let me just have your hand up a little bit higher.
Yes. 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 Yes.
And you could do this for both sides, of course. Also coming in, as we're going to take a look at what happens with a little bit of a sharper feeling. I'm going to use a little bit of a blunt end, okay? But can you feel that?
Yes.
That has a different feeling than the Kleenex. So I'm going to have you close your eyes again.
Okay.
Tell me when you feel that.
Yes. Yes. Yes.
Take your hand, lift that up for me again.
Yes. 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 Yes.
Okay? And again, through this side, clinically, would be done. All right? I'm going to be looking at reflexes now. So I'm going to take this hammer. I'm not going to hit you hard, but I'm going to just come and give it a little tap. Okay. You just try to be relaxed, okay, to that. So I'm going to come through to this side here, and I'm going to go and yours back. I'm going to have you turn this way one time for the camera's purposes, for this clinical. I'm going to come in at a kind of a glancing angle. Turn back. A little bit of a blip, nice looking reflex there. Okay, good. I'm going to do that on both sides in a clinical situation. We're going to look at muscle strength now. I'm going to have you just go ahead and bring your shoulders up. Good. Hold right there. Super. This time I'm going to just bring this arm over top. Don't let me pull your arm down. Super. Do that on the other side, just to be thorough on this one. Good. Can do both in clinical if you feel like that's warranted, or let this arm down and do separate deltoid. Good. Biceps. I know you're strong, so let's do triceps up here. Super. Wrist extension as an alternative, or flexion. Thumb extension, which is going to be hitchhiking, holding the thumb here. Don't let me push you down. Good. And alternative, just put that right there. See how that does. Last of all, I'm going to put my fingers in between here, little fingers, and you just hold and don't let me slide out. Very good. Okay. Now, I'm going to take and look at just a couple more reflexes that you have, and I'm going to have your finger here. I'm going to give a little noxious stimuli, so I don't mean to hurt you. Okay. Relax your hand. A pinching feeling. Move your head several times up and down. Good. And then I'm going to have you bring your head up straight. I'm going to relax your hand. Good. I'm going to come around the front here. Take your hands. And I'm just going to have you let me turn them quickly that way. Good. Okay. At this point, would be doing a slump test and a potential Babinski, which we looked at in the other section. So we also want to make sure we're looking at when we were doing the range of motion, just to let you know, we won't do it twice, but we'd be looking at dural kind of conditions, so any kind of overpressure what we did in the head would give us an indicator of the dural system. So in here, all we need to do is bring your hand back. Look at a T1 stretch for our general upper limb tension. Just looking at your carotid pulse here. Feels nice. Check down into the brachial and to the radial area. Good. Since I have you there, let me just have you turn your head this side and tuck your chin in, take a deep breath and hold it. I'm going to have you hold it for a few seconds. Good, I can still feel your pulse. Great. And thank you very much.